You are getting the video? Hello? Okay. So yesterday we were discussing about the inhalant anesthetics, their mechanism of action and the classification of the inhalant anesthetics were being discussed yesterday, and we had seen this particular classification in which the inhalation anesthetics were classified as gas and volatile liquids. The gas was the nitric oxide, which was invented in 1844, or the gas, and the other volatile liquids like ether, halothane, enflurane, isoflurane and desflurane, and also the sevoflurane are the anesthetics, volatile anesthetics. And the intravenous anesthesia is concerned, varieties of the agents are there. The inducing agents like thiopentone sodium, methoxytone sodium, propofol and etomidate. These are the intravenous agents, and the benzodiazepines are the slower acting agents. The classical examples are the diazepam, lorazepam and midazolam, alprazolam and many more. The dissociative anesthetics like ketamine, which act on the NMDA receptor, and the neurolept analgesia, this example is fentanyl and droperidol and many more. So the coming to the kinetics of inhalation anesthetics, the pharmacokinetics of the inhalation anesthetics are, these are the gases or vapors that diffuse rapidly across pulmonary alveoli and tissue barriers. Most of the tissue barriers are being what you call as passed with this particular inhalant anesthetics. So the inhalation anesthetics, the depth of anesthesia depends upon the potency of the agent, especially the MAC is an index of the potency. As we have, the MAC is the concentration of an inhalant anesthetic in the alveoli, which causes the painlessness or analgesia in case of the 50% of the patients administered, and its partial pressure, especially in case of pain, that means which will indicate how much quantity of the anesthetic has entered the brain, while induction and recovery depending upon the rate of the change in PP in the brain. So the rate of induction is also depending upon the many factors. Of course, what we can see is here, so the rate of induction is also depending upon the change in the PP in the brain. So the recovery, faster recovery, and the partial pressure will be more and more, so that it will dissociate from the brain to the surrounding tissues and to the blood, so that the recovery becomes fast. And this is the pharmacokinetic of inhalation anesthetics, in which the pathway is like this. The inhalation anesthetics, the depth of anesthesia is depending upon both MAC and PP, or partial pressure of the gas in the brain. So here you can see that the gas mixture is administered here through the lungs, and it passes through series of tension gradients here, and there are varieties of the factors are there. In the number one is the arterial pressure and venous blood pressure will be there. And so whenever the anesthetic is administered, it will enter the alveoli, and the surrounding blood capillaries will take up that particular anesthetic agent into the arterial blood or capillaries make the artery, then it will enter the central nervous system, and many other tissues like the midbrain, the other brain is being passed, and of course a part of the drug or the anesthetic is metabolized also, and few part of the anesthetic is also entering the other part of the brain, and also after entering to the brain, then from the venous blood they are coming back to the heart, and then once again they are pushed to the lungs. So many of the gases are excreted to lungs, and also they are dependent on the kidney for their excretion is concerned. The blood-brain barrier in the brain will prevent certain anesthetics to enter the brain, whereas most of these lipid-soluble solvent anesthetics like ether and the chloroform etc., they enter the blood-brain barrier without any hassle. So the drugs are whenever the drugs are administered, they enter the capillary and there will be a little pressure will be there, and this is called as the partial pressure. Then other tissues it will go, then the metabolism will also occur at the simultaneously, then the anesthetic dose will enter the brain, then it will also enter the venous blood, and from other tissues, here it will go to the other tissues, and in here the other tissues it will be returned. So once again it will come back to the heart, then from the heart to the lungs. So sometimes the excretion also takes place through the lungs. So another important terminology is here, that is the blood gas partition coefficient. So the solubility of an anesthetic agent in blood is quantified as the blood gas partition coefficient. So this is one of the important parameter in deciding the depth of the anesthesia. So this is defined as the ratio of concentration of an anesthetic in the brain phase to the concentration of the anesthetic in the gas phase, when anesthetic is in the equilibrium between two phases. So whenever you administer a gas, then it should reach the equilibrium state between the blood phase of the brain and also the gas phase in the alveoli. So there should be an equilibrium between in two phases. One is gas phase and another one is the brain phase. So both of these should reach a equilibrium, and the lower the blood gas coefficient, faster the induction and recovery. So if the blood gas coefficient is low, means that the ratio between the concentration of the anesthetic in the blood phase to the concentration of the anesthetic in the gas phase, if it is low, then the faster the induction and recovery is also faster. The classical example is nitric oxide. Higher the blood gas coefficient, means the ratio of the pressure of the gas and the anesthetic in gas phase, in the anesthetic in the equilibrium, especially brain, if it is high, then induction is slower and recovery is also slower. That the classical example is the halothane. So the blood partition coefficient plays an important role in judging the induction and recovery stage of any gaseous anesthetic. Especially the alveoli in the blood, then especially so the alveoli in the blood and brain factors affecting the partial pressure of the anesthetic attained in the brain are varieties of the factors. They are affecting the partial pressure in the brain, and it relates to the partial pressure of the anesthetic in the inspired gas or the inhaled gas. This is the proportional to its concentration in the inspired gas mixture. So many times it is a single gas, and many times it is a mixture of two or more gases. And higher the inspired tension, more anesthetic will be transferred to the blood. So if you administer the gas with more and more pressure, more and more administration, more and more concentration which will reach the blood. Thus, induction can be increased by administration of gaseous anesthetic at high concentration in the beginning. So this mean to say that initially the partial pressure should be high. That means more and more gas is required during the induction stage. Then it will be maintained by maintenance dose. And another thing is the pulmonary ventilation. So it governs the delivery of the general anesthetic to the alveoli. Pulmonary ventilation. and hyperventilation will bring in more anesthetic per minute, and respiratory depression will have the opposite effect. If the lung is having more and more, what you call as the ventilation, then hyperventilation bring more and more anesthetic gas to the alveoli, and if the respiration is depressed, then the quantity of the gas that reaches the alveoli will be less, and influence of the minute volume on the rate of induction is greatest in case of the agents which have high blood solubility, because the partial pressure in blood takes long time to approach the partial pressure in the alveoli. So whenever we are going to administer any inhalant anesthetics, the minute volume, a volume that has entered the alveoli, and it will depend upon the rate of induction of the anesthesia, and it will be great in case of agents which have high blood solubility. More and more blood solubility of a gas will increase their concentration in the surrounding capillaries. So, however, it does not affect the terminal depth of anesthesia attained at any given concentration of the general anesthetic. So, the concentration or solubility of a gas agent in the blood will not affect the terminal depth of the anesthesia at any given concentration of the general anesthetic, because whenever the gas is soluble more and more in the blood, and also it penetrates the alveoli faster, but it does not guarantee that the recovery phase is also in a similar pattern. So once the gas has entered the blood, then the metabolism takes place. Sometimes the metabolite may also be active, so that it takes more and more time to recover from that anesthetic phase, or sometimes it may recover very early also. And the alveolar exchange is the exchange of the gases, general anesthetics, and they diffuse freely across alveoli, but if alveolar ventilation and perfusion are mismatched, the attainment of the equilibrium between alveoli and blood is delayed. So this is the one of the what you call as the exchange capacity of a general anesthetic. So it will freely diffuse across the alveoli, but if the alveolar ventilation and perfusion are mismatched, it is not good, as occurs especially the pulmonary edema and emphysema and lung disease. The attainment of the equilibrium between alveoli and blood is delayed. In any disease of the lungs, the absorption of particular anesthetic agent from the alveoli, in a disease case, it will be delayed. So that the well perfused alveoli may not well ventilated blood draining, and these alveoli carries less anesthetic and dilutes the blood coming from a well ventilated alveoli. So it doesn't mean that the alveoli may not well ventilated and the blood draining capacity of that alveoli, then if it is having less capacities, then less anesthetic will enter the blood and dilutes the blood coming from well ventilated alveoli. So the induction and recovery in such cases are very slow. Suppose if the lung is damaged and alveoli are damaged, then the absorption of the anesthetic agent from the alveoli is going to be drastically decreased. Hence, induction and recovery of the anesthetic is slow. The fourth factor is solubility of anesthetic in the blood, and this is the most important property, solubility determining induction and recovery, because the large amount of the anesthetic that is highly soluble in blood must dissolve before its partial pressure is raised. So the solubility of an anesthetic in the blood is also very, very important. If more and more solubility is there, then the induction will be faster. The rise as well as the fall in partial pressure in blood and consequently induction as well as the recovery will be slow. So the partial pressure, if the pressure is also more and if the drug is not soluble in the blood, then there is no use. So the induction becomes late, just like the halothane. Whereas the ether and nitrous oxide, they are very highly soluble in blood, and because of this thing, the induction will be very fast. And drugs with low blood solubility, example the nitrous oxide, sevoflurane, desflurane, induce quickly. So because if they are soluble in the what you call as the blood, then they will not be available for acting on the GABA receptors. Blood gas partition coefficient is also denoted as I, given by the ratio of concentration of the anesthetic in the blood. That to that in the gas phase at equilibrium is the index of solubility in the blood especially. So the blood gas coefficient, as we have discussed already, is an important factor, and the ratio of concentration of anesthetic in blood to that of the gas phase. If it is the equilibrium, then that is the index of solubility of the general anesthetic in blood. And apart from solubility of the anesthetic in blood, the solubility of anesthetic in other tissues and brain tissues is also an important factor for the determination of the duration of action of an anesthetic and also the recovery and induction. So, relative solubility of the anesthetic in blood and tissue determines its concentration at the tissue at equilibrium. So, most of the gases are equally soluble in lean tissues in blood, but more soluble in fatty tissue. That's why most of these volatile agents are soluble in fat tissues, and they are lipid soluble, and they are going to pass the blood brain barrier, and the fatty tissue is accumulated with that of the anesthetic agent. And anesthetics with higher lipid solubility like the halothane continue to enter adipose tissue for hours and also leave it very slowly. That's a very common factor in the barbiturate type of the anesthetic. For example, the halothane, whenever it is administered, it will enter the tissues because it has got very high lipid solubility and enter the adipose tissues of the body. And later, after the cessation of the induction of anesthesia is over, slowly the gas is released. Slowly the halothane is released from the tissue, and it will have certain effect on the brain. And the concentration of these agents is much higher in white matter than in the grey matter. That means in the brain itself, the concentration of the halothane and other anesthetics which have very high lipid solubility will be different. So it is much higher in white matter and when compared to the grey matter, especially in the brain. And also the another factor is cerebral blood flow. Brain, especially in brain, is a highly perfused organ, means it is one of the organ to which the high quantity of the blood is pumped from the heart, and hence as such general anesthetics are quickly delivered to it immediately after injection from the immediately after administration from the lungs. It will enter the alveoli. From the alveoli, it is going to enter the pulmonary vein. Then from the heart, it is pumped to the central nervous system or the brain. So this can be hastened by the carbon monoxide inhalation, which causes cerebral vasodilatation, and induction recovery are accelerated both. So CO2, carbon dioxide, stimulates the respiration, and this also speeds up the transportation, both CO and CO2. So because of this thing, usually the pure anesthetic is not administered. So it will be administered with the carbon dioxide, also about 5% carbon dioxide. So this will speed up the transport of the anesthetic into the brain and also the reversal of the anesthesia. The elimination of the anesthetics is also another important factor in case of the pharmacokinetics. When anesthetic inhalation is discontinued, gradients are reversed and the channel of absorption, especially the pulmonary epithelium, becomes the channel of elimination. The same way how the anesthetic has entered the circulation through the alveoli will become the route for the elimination also. So it will be reversed, and it becomes a channel of the what you call as the excretion or elimination. So all inhaled anesthetics are eliminated mainly through lungs. Please remember, all inhaled anesthetics are eliminated mainly through lungs. So some factors which govern induction also govern recovery. As usual, anesthetic in general continue to enter and persist for longer periods in adipose tissues because their high lipid solubility and low blood flow to the fat tissues. So the adipose tissues may be the belly fat, or the fat may be present in the other tissues. It will absorb lot of the anesthetic agents which are soluble in fat, and during the recovery it is going to release the anesthetic agent slowly as per the lipid and the drug partition coefficient. So muscles occupy an intermediate position between the brain and adipose tissue. So the muscles will also, because during the anesthetic phase, even though the muscles are not what you call as the exercise is not there, even then they will be supplied with the blood with the particular gas, and gases are eliminated unchanged. Most of the gases are eliminated unchanged through the lungs, and metabolism is significant only for halothane, which is more than 20% metabolized in the liver, and others are practically not metabolized in the liver, whereas they are excreted as such in the lungs, except the halothane. And recovery may be delayed after prolonged anesthesia, especially in case of more lipid soluble anesthetics, whereas like the halothane and isoflurane, if they are more and more lipid soluble, then they will be soluble in case of the adipose tissues, and hence the reversal is also late. And because large quantities of the anesthetic have entered the muscle and fat, and because of this thing which is released slowly into the blood. Second, gas effect and diffusion hypoxia is one of the factors to be learned in the central nervous system pharmacology is concerned. What's the second gas effect? So here in the initial part of the induction, diffusion gradient from alveoli to blood is high, and larger quantity of the anesthetic is entering the blood. That's very well understood. So in the initial part, the diffusion gradient from alveoli to blood is high, and larger quantity of the anesthetic is entering the blood. Then if the inhaled concentration of anesthetic is high, substantial loss of the alveolar gas volume will occur, and the gas mixture will be sucked in, which is independent of ventilatory exchange. Gas flow will higher than the tidal volume. So that's the volume which is present in that's the quantity of the anesthetic present inside the lung tissue is known as the tidal volume, and as the concentration of the anesthetic is high, and there is induction of the anesthesia, and absorption of the anesthetic agents may also be high, and this is significant only with nitrous oxide, since it is given in the 70 to 80% concentration, though it has very low solubility in the blood. That's the 1 liter per minute of the nitrous oxide enters the blood in the first few minutes. As such, the gas flow is 1 liter per minute, and it is higher than the minute volume. If another potent anesthetic, so if two gases with one is high and another one is low penetration capacity, and the example is the halothane is being given at the same time simultaneously two gases are given, then both will be delivered to the blood at the rate of 1 liter per minute, higher than the minute volume, and induction will be faster. So if you mix two gases just like halothane or nitrous oxide simultaneously, then the induction of the inhalation anesthesia will be faster, and this is known as the second gas effect. So simply to simplify this thing, if you administer two gases simultaneously, the capacity to induce anesthesia of one gas will be more and more it is increased. This is known as the second gas effect. So here you can see that from the trachea, sevoflurane and nitrous oxide both are administered, especially in the through the trachea, then it is going to the lungs and it will enter the alveoli. So if two gases with different partition coefficients and different properties also, then if one is increasing the potency and the latency of the another thing, then the induction of the anesthesia will be faster. So this is known as the second gas effect, or otherwise two gas effects can also be called to this thing. And the reverse occurs when nitrous oxide is discontinued after prolonged anesthesia. The nitrous oxide is having low blood solubility, whereas the halothane is having high blood solubility, and this diffuses into alveoli and dilutes the alveolar air. The partial pressure of oxygen in alveoli is reduced. So the resulting hypoxia is called as diffusion hypoxia, and this is not much consequence if cardiopulmonary reserve is normal, but may be dangerous as if it is very low. So the diffusion hypoxia can be prevented by continuing 100% oxygen inhalation after discontinuing the anesthetic gas, especially the nitrous oxide. So this is done instead of the straight away switching over to the air to recover very fastly from the anesthetic agent. So apart from this one, the techniques of inhalation anesthesia, there are different techniques are there how to administer these agents. So different techniques are used according to the facilities available, the type of the agent used, the condition of the patient, and type and duration of the operation. So this will not there will be a lot of variation between the patient to patient, as it depends upon the surgical procedure duration. So if it is a prolonged duration surgery, then a different anesthetic agents will be used. So the surgical time, if it is required very less, like sometimes a minor surgery, then the gaseous agents will be different. So here then the technique number one is open drop method. Open drop method. Here the liquid anesthetic is poured over a mask with gas, and its vapor is inhaled by the patient. So usually this is what we observed in case of movies and other things. They are putting the anesthetic agent in the kerchief and many other things, then putting it on the nose of the persons to kidnap. And a lot of anesthetic vapor escapes during this procedure surroundings, and the concentration of the anesthetic breathed by the patient cannot be determined. So if we use this open drop method, then we cannot assure how much quantity of the anesthetic agent is being inhaled by the patient. So then it is a wasteful and can be used only for cheap anesthetic. So whenever we are using the costly anesthetic like halothane, enflurane, sevoflurane, etc., then this is what you call as it is a costly habit, whereas certain anesthetics like ether and other things which are cheap in price, this can be used. So here this is now only used to the peripheral areas. So the ether is the only agent administered by this method, because it is one of the very cheaply available agent, especially in case of the children for minor surgical procedures. So ether, a gas is dipped in ether and administered on the face of the patient without any specified mask or anything. Then the minor surgeries can be conducted. Another technique of the anesthesia is through anesthetic machines. So this is very popular thing nowadays, and here use is made of the gas cylinders and a carrying agent. Specialized graduated vaporizers are there, and flow meters, unidirectional valves, corrugated rubber tubing and reservoir bag. All these will be present, especially in case of the anesthetic machines. So because of this thing, the anesthetic machines are very costly, just like the Boyle's apparatus and many more. So these require specialized graduate vaporizers and flow meters, unidirectional valves and corrugated rubber tubes, and also a reservoir bag. You might have seen in many times, especially this type of the mechanic. And the gases are delivered to the patient through a tightly fitting face mask or endotracheal tube. Here no gas is lost. Without any loss, the gas is administered using a very tight face mask and also the endotracheal tube. And the administration of the anesthetic can be more precisely controlled, and in many situations its concentration is estimated, and respiration can be controlled and assisted by the anesthetic, because since the machine is handling everything, we can control the respiration using the oxygen, and also the machine will monitor the quantity of the anesthetic agents to be infused. And another thing is the open system. In this same thing, whenever you are using the machines, once again there is an open system. The exhaled gases are allowed to escape through a valve, and a fresh anesthetic mixture is drawn each time. That is system is called as the open system. No rebreathing is allowed, and the flow rates are very high, and more drug is consumed in this open method. However, the predetermined oxygen and anesthetic concentration can be these can be measured here. Whereas the closed system, the patient rebreathes the exhaled gas mixture after it has circulated through soda lime, which absorb the carbon dioxide. So in the closed system, the exhaled gas will pass through a soda lime which absorbs the carbon dioxide. So here only as much oxygen and anesthetics have been taken up by the patients are added to the circuit once again, because the exhaled gas is once again it is inhaled, and the flow rates are low, and here the requirement of the anesthetic will also be very less, and this is useful for expensive and explosive agents. Little anesthetic escapes in the surrounding agent, because many times this ether and other agents are highly explosive in nature, because they will catch fire suddenly, then there is the chance of the explosion. So to avoid such thing, closed system is maintained. The halothane, isoflurane, desflurane can be used through closed system, whereas the open system is used for the ether only, diethyl ether. However, control of the inhaled anesthetic concentration is improvised, so that is not possible. And another system is there, that is semi-closed system. Here partial rebreathing is allowed through a partially closed valve. So the conditions are intermediate with the moderate flow rates. A partial here the machine operated things will be there, and there will be a valve which partially closes the exhaled and inhaled gases. So the properties of an ideal anesthetic. There are varieties of the properties to become an ideal anesthetic, and it should be very pleasant and non-irritating to the trachea or the respiratory tract and should not cause nausea or vomiting. Suppose the gas smell is having pleasant in odor, then the patient feels very happy, or else if it is pungent odor, then he may have the nausea or vomiting. And induction recovery should be very fast with no after effects or hangovers effect should not be there. This is for the patient, whereas the ideal property of an anesthetic to the surgeon is it should provide adequate analgesia, the pain should be drastically reduced, and also it should cause the immobility immediately and the muscle relaxation should be sufficient. These are the very, very important criteria for the surgeon. It should produce analgesia, because whenever he is putting an incision on the skin or anything, the patient should not feel the pain at all, and he or she should be immobile as early as possible, and the muscles should be relaxed very fastly, and it should be non-inflammable, because it's always dangerous to operate in case of the surgical theatre, and the non-explosive, non-inflammable and non-explosive, both characteristics are very, very important, because many times the thermocautery tube is used for stopping the bleeding. So it is very dangerous. The gas may get the fire and there will be a big explosion will be there. So the gaseous agent should be non-inflammable, non-explosive, and should induce the adequate analgesia as fast as possible, immobility and muscle relaxation. These are the ideal characteristic of when the surgeon is concerned. For anesthetist, so the anesthesia is one of the very specialized branch of the medicine now. A specialized persons will be there to induce anesthesia in patients. Then for the anesthetic, the administration should be very, very easy. It should not require the very costly machines. It should be usually controllable, and it should be versatile. These are all the characteristics. Whereas the margin of safety should be very, very wide, and there should not be any fall in the BP, because this is one of the important criteria. As soon as the anesthetic agent is being administered, the blood pressure starts falling in many of the anesthetics, and margin of safety should be wide, means it should not be so dangerous. If it is narrow, then the anesthetic dose and the dose caused to death will be very low margin. That should not be there. Heart, liver and other organs should not be affected. That's also another property. It should be potent, so that low concentration are needed and oxygenation of the patient does not suffer. It's also very important. The anesthetic agent should be very potent, so that the very fast induction occurs, and the low concentration should be needed for the patient, and the oxygenation should not be hampered, and rapid adjustments in depth of the anesthesia should be possible, because sometimes the surgeon may say that patient is having some pain sensation and please induce certain anesthetic agent. Then rapid adjustments in the flow should be allowed. Then it should be very cheap, stable and easily stored. So the anesthetic agent should be very, very cheap, because the patient cannot afford the very, very costly anesthetics, and it should be stable in the room temperature itself, because many times the volatile anesthetics, if they are kept open for few minutes also, they get evaporated. So it should not be like that, and it should be easily stored, and many times the anesthetic agent need to be stored in a cool and dark place, and by chance also if they are exposed to sunlight, there is a chance that these will get evaporated, and it should not react with rubber tubing or soda lime. So there are so many rubber tubings in the anesthetic machine. So the anesthetic should not have the interaction that of the rubber tube and also the soda lime, which is going to absorb the exhaled oxygen, this carbon dioxide. So it should not react with all these type of the things. And classification of the inhalation gas, already we have done. The inhalation gases, nitric oxide, and the volatile liquids are the ether, halothane, isoflurane and desflurane, and also the sevoflurane. Ether, halothane, isoflurane, desflurane and sevoflurane. These are called as the fluorinated gaseous agents. And this table is an important table which notes the physical and anesthetic properties of the inhalation and anesthetics. So here you can see the boiling point of the ether is 35, whereas the halothane is 50, isoflurane is 48, desflurane is less, that's the 24, sevoflurane is 59, and nitrous oxide itself is a gas. So the boiling point, as it's become less and less, it becomes more and more inflammable. And the inflammability, you can see here, both the inflammability and the explosive property of the ether is high, whereas the halothane is non-inflammable, means it will not catch fire. Of course, the all other are the non-inflammable, whereas the ether is highly explosive. Whereas the irritancy, as the odor, the ether is having very pungent odor, whereas many times the patients disagree the odor of the ether. It's having one of the, whereas the halothane, it's having very smell very pleasant, whereas the isoflurane, it is not so pleasant, unpleasant, whereas the sevoflurane is pleasant in the odor. Whereas the oil partition coefficient, the ether is 65, a factor, whereas the halothane is more, whereas the isoflurane 99 and desflurane it is 19, whereas the sevoflurane it is 50 and nitrous oxide, the oil gas partition coefficient is very less. So the induction is also less here. So the blood partition coefficient, blood gas partition coefficient is 12.1, that's 2.3 in case of halothane and 1.4 and lesser values for the other anesthetics. So the induction of the ether is somewhat slow, halothane is intermediate, whereas the desflurane and sevoflurane it is very fast with that of the nitrous oxide. Induction of nitrous oxide is very fast because the oil gas partition coefficient is very low and blood gas partition coefficient is also low. The induction, the muscle relaxation of the ether is very good, whereas halothane is fair, whereas the isoflurane, desflurane, sevoflurane and nitrous oxide it is good, whereas for nitric oxide it is muscle relaxation is very poor. So the other muscle relaxants need to be administered while the operation is being carried out. So coming to the anesthetic agents, fast acting, especially intravenous anesthetics, fast acting drugs and slower acting drugs are there. So fast acting drugs like thiopental sodium, methohexaton sodium, the propofol and etomidate are very fast acting, whereas the slow acting drugs are benzodiazepines like the diazepam, lorazepam, midazolam. The dissociative anesthetics is the ketamine and opioid anesthesia, and also the fentanyl and droperidol. Cyclopropane, trichloroethylene, methoxyflurane and enflurane are no longer they are used because of their varieties of the properties, including the toxicity and also the inflammable nature of these drugs. Whereas the commonly used agents are thiopentone, the propofol. Nowadays propofol is very commonly used. Coming to the inhalation anesthetics, the number one is the nitric oxide, N2O is the formula, and it is colorless, odorless, heavier than air, non-inflammable gas supplied under the pressure in steel cylinders. So it is non-irritating. whereas the ether is irritating. This is non-irritating but low potency anesthetic. Unconsciousness cannot be produced in all individuals without the concomitant hypoxia. So the maximum alveolar concentration is 105, implying that even pure nitrous oxide cannot produce adequate anesthesia. So that means it's 105, it's very high, and at 1 atmosphere pressure. And the patients maintained on 70% nitric oxide plus 30% oxygen along with muscle relaxants often recall the events during the anesthesia, but some lose awareness and completely. So what we can say is the result is little bit erratic, because some will get very faster induction, some will get less type of the induction. So nitrous oxide is a very good analgesic. Even 20% produces analgesia equivalent to that produced by the conventional doses of the morphine, and muscle relaxation is minimal. Neuromuscular blockers are mostly many times it is required, and the onset of nitrous oxide action is quick and smooth, but thiopentone is often used for the induction because the nitrous oxide is not causing much muscle relaxation, and the recovery is very rapid because of its low blood solubility. And second gas effect, and the diffusion hypoxia occurs with nitrous oxide only. So the post anesthetic nausea is not marked. Many times after administration of the anesthesia, many of the patients start vomiting because of the stimulation, and also the chemoreceptor trigger zone stimulation, and also the pungent odor of the anesthetic. That's also very important. It tends to increase sympathetic tone, which counteracts the weak direct depressant action on the heart and circulation is concerned. And the nitrous oxide is generally used as a carrier and adjuvant to other anesthetics. A mixture of 70% nitrous oxide, 25 to 30% oxygen, and 0.2 to 2% another potent anesthetic is employed for most of the surgical procedures. So this is a standard formula. Because the nitrous oxide is one of the cheap anesthetic, we can use it for many of the purposes. So in this way, the concentration of the another anesthetic can be reduced to 1/3 for the same level of the anesthesia is concerned. And the nitrous oxide has little effect on the respiration, heart rate and BP, which is very much required in case of the general anesthetic agent. And the breathing and circulation are better maintained with mixture than the potent anesthetic given alone. So the mixture of the nitrous oxide, 25 to 30% oxygen, and also 0.2 to 2% of maybe any other agent like halothane, enflurane, sevoflurane is always employed. And the nitrous oxide can expand pneumothorax and other abnormal air pockets in the body. So these are all the certain unwanted things in which the pneumothorax occurs. So the thoracic cavity will be accumulated with air if nitrous oxide is very commonly used. So the increased cerebral blood flow and tends to elevate intracranial pressure. Of course, this is not required, especially intracranial pressure should not be increased. So it increases cerebral blood flow and tends to elevate the intracranial pressure. So as a sole agent, nitrous oxide can be used with oxygen for dental and other surgeries. So it is non-toxic in the normal dose. It is non-toxic in usual anesthetic dose, but to the kidney, liver and brain in the administered dosage. So however, prolonged nitrous oxide anesthesia has potential bone depressive action and cause peripheral neuropathy also possible. And metabolism of nitrous oxide does not occur, it is directly excreted from the body by the lungs as soon as the source of anesthetic is removed, and it is one of the most cheap anesthetic agent, and very commonly the nitrous oxide is used. So it is also called as the laughing gas. The another agent is the diethyl ether or ether is also the important agent. So the formula is C2H5O, C2H5, and it is highly volatile liquid, produces irritating vapors which are highly inflammable and catch fire and get explosion. So ether is a potent anesthetic, produces very good analgesia and marked muscle relaxation, reducing acetylcholine output from the motor nerve endings or the vagal stimulation. The dose of competitive neuromuscular blocker should be reduced to the 1/3. So to get a very good muscle relaxation, a competitive neuromuscular blockers should be administered, and it will reduce the dose to 1/3. And it is highly soluble in case of blood. Induction, because of this thing, its induction is prolonged and unpleasant with struggling, then breath holding, salivation, and marked respiratory secretions. So that's why the atropine should be always given as the pre-medication to prevent patient from drowning in its own secretions, because the ether will produce lot of secretions in the airway, then it may go inside the lungs and the patient may drown in his own fluids. So that's why the atropine is given, which is a very good anti-secretory agent. Recovery is slow, potent anesthetic, nausea, vomiting, retching are very marked. Respiration and BP are generally, they are very well maintained because of the reflex stimulation of the sympathetic tone. And another property is it is not going to sensitize the heart to adrenaline, and it is not hepatotoxic agent. So ether is not used now in the developed countries because of the unpleasant and inflammable properties, whereas the underdeveloped countries still it is used only in few developing countries, particularly in peripheral areas. So because it is cheap and can be given by open drop method through congestion of the eye, soreness of the trachea, the either burns or face may also occur. So if the patient is administered with open method, then the fire will also catch if the administering a person is little careless. And without the need for any equipment, it is relatively safe even in experienced hand. In inexperienced hands also, this agent is safe with all the demerits and merits. So here there is a difference between the ether and chloroform. So the ether is readily diffusible and volatile, whereas the chloroform is heavier, vapor, and less volatile. So the ether is irritating to the respiratory mucosa, whereas the chloroform is slightly soothing to the respiratory mucosa. The ether is irritating to the kidneys, whereas it is non-irritating to kidneys, chloroform. Whereas the ether reflexively stimulates the heart, and the chloroform is going to depress the heart. So the ether, slower in action, long period of the excitement will be there, whereas the chloroform is quicker in action, short period of excitement. So the ether is less persistent in action and the chloroform is more persistent in action. And the greater concentration required, especially the ether, 70% of the drug is required, whereas the smaller ration of the drug into air is required. The ether is highly inflammable, whereas the chloroform is non-inflammable. The ether is compared to the chloroform, it is more expensive, whereas the cost of the chloroform is less when compared to the ether. Whereas compared to the modern anesthetic agents, ether is very cheap in nature. So the third agent is the halothane, or it's also known as fluothane. It is a volatile liquid with sweet odor, non-irritant, non-inflammable. Solubility in blood is intermediate. Induction is reasonably quick and pleasant. So the halothane is having the structure of, it's a fluorinated anesthetic agent, because the fluoride moiety, 3 fluoride moiety and a bromide moiety, hydrogen and chloride are there in the structure. You can see the structure relationship. So the halothane, or it's also known as fluothane, is a potent anesthetic, and precise control of administered concentration is essential. For induction, just 2 to 4% and maintenance 0.5 to 1% is delivered by the use of a closed system or special vaporizer. It is not a good analgesic or muscle relaxant, but it potentiates the competitive neuroblockers. So always the muscle relaxants like the competitive neuromuscular blockers should be administered. Halothane causes direct depression of myocardial contractibility by reducing intracellular calcium concentration. And moreover, sympathetic activity fails to increase the reflexly. Of course, the cardiac output is reduced with deepening of the anesthesia, and the blood pressure starts falling early and parallels the depth of that particular also of the anesthesia. A 22 to 30 millimeter mercury drop in DP is a very common feature in case of the induction of halothane anesthetic, and many vascular beds dilate, but total peripheral resistance is not significantly, it is reduced, and the heart rate is reduced by vagal stimulation. Acetylcholine is secreted and heart get relaxed. Atropine, of course, it is used as the pre-anesthetic to make the heart rate stable, and direct depression of sinoatrial node automatically, and the absence of baroreceptor activation even when BP falls. That's also another thing, and it trends to sensitize the heart to arrhythmogenic action of the adrenaline. So the electrophysiological effects are the conducive to re-entry tachycardias, and they occur, of course, very occasionally. And halothane causes relatively greater depression of respiration. Breathing is very shallow and rapid, and the partial pressure of the carbon dioxide in blood rises if respiration is not assisted by administration of the oxygen, etc. And the cerebral blood flow increase, ventilatory support with added oxygen is frequently it is required, and it tends to accentuate the perfusion ventilation mismatch in the lungs by causing vasodilatation in case of the hypoxic alveoli. That's also one of the features. The pharyngeal and laryngeal reflexes are abolished here early, and coughing is suppressed while the bronchi is going to dilate. As such, halothane is preferred for asthmatic patients also. It inhibits the intestinal and the uterine contractions, and this property is utilized for facilitating external and internal version during the late pregnancy. However, its use during the labor can prolong the delivery because it is going to relax the uterus muscles, and increase postpartum blood loss also may be increased. And urine formation is decreased during halothane anesthesia. This is primarily due to low glomerular filtration rate as a result of fall in the blood pressure. And also the hepatitis occurs in rare susceptible individuals, maybe in 1 in 35,000 or 1 in 10,000. So, but it is only after repeated administration of this anesthetic agent, and those with familial predisposition also important. A metabolite of the halothane is probably involved, which causes the chemical or immunological injury. Then the genetically determined malignant hyperthermia is one of the important terminology here, because the body temperature rises to a very high extent, which is not responding to any non-steroidal anti-inflammatory agents, the malignant hyperthermia. Then many susceptible subjects have the abnormal RYR1, that's the ryanodine receptor, the calcium channel at the sarcoplasmic reticulum of the skeletal muscles, and this channel is triggered by halothane to release the massive amount of the calcium intracellularly, causing persistent muscle depolarization and contraction and increased heart heat production. Of course, the succinylcholine, it accentuates the condition, especially the muscle relaxation, and the rapid cooling bicarbonate infusion occurs, especially when 100% oxygenation is always it is required. Whereas it is going to cause the what you call as the malignant hyperthermia, especially it causes that particular condition. Malignant hyperthermia, the what you call as the increase in the body temperature to the extent of 2 or 3 degree Fahrenheit, and the elimination may become continue. And the halothane is a popular anesthetic in developing countries because it is relatively cheap and non-irritant, non-inflammable, and pleasant in smell and relatively rapid action. So it is particularly suitable for the use, especially in case of children, both the induction as well as the maintenance. The dantrolene is used for the treatment of the malignant hyperthermia. The adults, it is mainly used to maintain the anesthetic after IV induction. In developed countries, it has been largely replaced by the new agents which are more costlier. Its deficiencies in terms of the poor analgesia and muscle relaxation are compensated by the concomitant use of the nitrous oxide, opioids or neuromuscular blocking agent. So apart from this one, the isoflurane, desflurane, the sevoflurane are also important anesthetics. They can be used very commonly. Isoflurane is a fluorinated anesthetic used in 1981 and currently the routinely used, very commonly used agent. It has been replaced by the isomer N-fluorine. So isoflurane is somewhat less potent and less soluble in blood as well as in the fat than that of the halothane. Compared to halothane, it produces relatively rapid induction and recovery and is administered through a special vaporizer. 1.5 to 3% induces anesthesia within very short time of 7 to 10 minutes, and 1 to 2% is used for the maintenance. Whereas all the uterine and skeletal muscle relaxation is very similar to that of the halothane, it is going to relax, and potentiation of the neuromuscular blocker is greater than that of the halothane. So the metabolism of the isoflurane is very negligible. Renal and hepatic toxicity is not encountered. So the nausea and vomiting is low, pupils do not dilate, and the light reflex is not lost even after deep level. The desflurane is a very new generation fluorinated congener of the isoflurane and is gained popularity as an anesthetic for outpatient surgery. Minor surgeries can be conducted. So it is highly volatile. A thermostatically heated special vaporizer is used to deliver a precise concentration of pure desflurane, and the nitrous oxide and oxygen is used as the carrier gas. So its distinctive properties are lower lipid solubility as well as very slow solubility in blood and tissues, and because of which induction and recovery are very fast, and the depth of anesthesia changes rapidly with change in the inhaled concentration. The sevoflurane is also the new polyfluorinated anesthetic and has properties very similar to that of the isoflurane and desflurane. So this is the structure which is containing many fluoride moieties, and solubility in blood and tissue as well as the potency are less than isoflurane but more than desflurane. So induction is common problem, and absence of pungency makes the pleasant and administrable through a space mask especially. So it possesses no problem with induction and selected for this purpose. So this is very commonly used for the pediatric patients, and the sevoflurane is suitable both outpatient as well as the inpatient surgery, induction as well as the maintenance, but its cost is very high. A 30 ml may cost more than 3 or 4,000 rupees, and it cost and need high flow open or semi-closed system, and very expensive to use, but the somehow safe in the induction of the particular anesthesia is concerned. So tomorrow we are going to discuss about the intravenous anesthetics.